Okay, now let us start with chapter 67 of your Apurva Sastry Essentials of Microbiology, which is about coronavirus infections, including COVID-19. In this chapter, we will be previewing severe acute respiratory syndrome SARS, Middle East respiratory syndrome MERS, and coronavirus disease COVID-19. Introduction. Coronavirus causes respiratory tract infection in man, illnesses ranging from mild common cold to severe disease like pneumonia. Morphology. Coronavirus are enveloped, carrying petal or club shaped or crown like peplomere spikes, giving appearance of a solar corona. They are large 120 to 160 nanometers, spherical virus having a helical symmetry. They possess linear positive sense ssRNA of 26 to 32 kilobase per size, largest among the non-segmented RNA viruses. Classification. Coronaviridae family contains two subfamilies, Coronaviridae and Toroviridinae. The former has been grouped into four genera, alpha, beta, gamma, and delta. Most of them infect animals except gamma coronavirus species, which are the pathogens of birds. Human infection is uncommon except few who have adapted to human conditions. Human coronaviruses. There are 7 recognized coronaviruses that are known to cause human infections. Most of them belong to beta coronavirus except the first two, 229E and NL63, which belong to alpha coronavirus. They spread by droplet transmission, though through coughing or sneezing, and also by close personal contact, such as touching infected persons or objects and then subsequently touching mouth, nose, or eyes. Severe acute respiratory syndrome SARS-CoV has caused an explosive epidemic in China in 2003 known as the severe acute respiratory syndrome. So these are all human coronavirus that produce milder and severe disease. The milder ones are human coronavirus 229E, NL63, OC43 and HKU1, while the coronavirus that cause explosive outbreaks were SARS-CoV, severe acute respiratory syndrome coronavirus, caused explosive epidemic called SARS in China in 2003. MERS-CoV, Middle East respiratory syndrome coronavirus, caused explosive epidemic MERS in Middle East in 2012. And SARS-CoV-2, severe acute respiratory syndrome coronavirus 2, causative agent of an ongoing explosive pandemic affecting the whole world 2019-20, called COVID-19 coronavirus disease. In this figure, we can see the electron micrographic picture of coronavirus, which shows a petal or club-shaped peplomeres. Now, the origin of MERS-CoV, SARS-CoV, and SARS-CoV-2. The origin is from bat, from which intermediate host for MERS-CoV is camel, and mode of transmission is close contact with mucosal fluids in man. Then the vector intermediate host for SARS-CoV is civet cat. With the direct or close contact, it can transmit the disease to man. And SARS-CoV-2, it is pangolin, from which it can get to man. History. SARS was first recognized in China in 2003 by WHO physician Dr. Carlo Urbani. He diagnosed it in a businessman who had traveled from China to Hong Kong to Hanoi, Vietnam. The businessman and the doctor who first diagnosed SARS both died from the illness. Epidemiology. During 2003 outbreak, the SARS virus spread from Asia to various regions of the world, causing nearly 8,098 cases in 29 countries with over 774 deaths. However, India remained free from the infection. Since 2003, no case has been reported from anywhere in the world. Source. A SARS-CoV infection in humans is believed to be contracted from animals including monkeys, Himalayan palm civets, raccoon dogs, cats, dogs, and rodents. Transmission. SARS-CoV is primarily transmitted from person to person, droplet or contact, mainly during the second week of illness, which corresponds to the peak of virus excretion in respiratory secretions. Clinical manifestation includes severe lower respiratory tract infection characterized by muscle pain, headache, sore throat, and fever, followed by the onset of respiratory symptoms, mainly cough, dyspnea, and pneumonia. In some cases, it may progress to acute respiratory distress syndrome. Treatment. There was no effective vaccine or drug available. Cases were managed only symptomatically. Infection control. Implementation of appropriate infection control practices was the main reason behind bringing the global outbreak to an end. Now, the Middle East respiratory syndrome MERS-CoV can cause severe form of low respiratory illness with a mortality rate of 35%. MERS was first reported in Saudi Arabia in 2012. Between 2012 January 2020, about 2,509 confirmed cases of MERS-CoV with 858 deaths, mortality 34.3%, have been reported to WHO from 27 different countries. India was not affected. Saudi Arabia accounted for 84%, 2,121 cases, including 788 related deaths of all of the cases, followed by other Middle East countries. The origin of virus is not fully understood, but according to the analysis of different virus genomes, it is believed that it might have originated in bats and was transmitted to camels sometime in the distant past. Source: Dromedary camels are the major reservoir host for MERS-CoV and an animal source of MERS infection in humans. Transmission, both zoonotic and human-to-human transmission, have been reported. Zoonotic MERS-CoV can be transmitted through direct or indirect contact with infected dromedary animals, and human-to-human it does not pass easily from person to person unless there is close contact, such as providing unprotected care to infected person by family members and healthcare workers. High risk acquired infection. People at increased risk from MERS-CoV infection include recent history of travel from Arabian Peninsula within 14 days, close contact of confirmed case of MERS, healthcare workers not following recommended infection control precautions, and people with exposure to infected camels. Elderly people are at higher risk for developing severe disease and complications, including death. High risk for severe disease. Elderly people with diabetes, renal failure, chronic lung disease, and immunocompromised persons are considered to be at high risk of severe disease from MERS-CoV infection. Clinical manifestation. Incubation period is about 2 to 14 days. Typical MERS symptoms include fever, cough, and shortness of breath. Pneumonia is common but not always present. Gastrointestinal symptoms, including diarrhea, have also been reported. Complications such as acute respiratory distress syndrome and kidney failure occur, especially in people with underlying comorbid conditions. Lab diagnosis. Detection of antibodies in serum indicates past exposure. ELISA is primarily used for screening of antibodies, which should be confirmed by immunofluorescence assay IFA and microneutralization assays. Molecular method. Detection of specific MERS-CoV RNA by real-time RT-PCR in respiratory specimens indicates active infection. However, lab confirmation requires the detection of at least two MERS-CoV specific genes, such as UPE and ORF1b, present in upstream of the E gene. Antigen detection. Capture ELISA detecting nucleic acid protein in nasopharyngeal aspirate is under evaluation. Treatment and prevention. No vaccine or specific treatment is currently available. However, several vaccines and drug trials are under development. Treatment is supportive based on patient's clinical condition. General preventive measures include regular hand washing before and after touching the animals, especially dromedary camels, and should avoid contact with sick animals. Avoid consumption of raw or undercooked camel products, including milk and meat, should be consumed only after pasteurization, cooking, and other heat treatments. Okay, now coming on to the coronavirus disease, the COVID 2019. Coronavirus disease 2019 COVID 19 is an acute respiratory disease caused by severe acute respiratory syndrome coronavirus SARS-CoV-2. It has caused an explosive catastrophic pandemic that has affected almost all the parts of the world and produced significant loss of lives in the worst financial crisis recorded ever since the World War II. Okay, now the epidemiology. History. SARS-CoV-2 originated from China and subsequently spread rapidly to affect rest of the world over a period of 3 to 4 months. One of the fastest spreading infectious diseases recorded in the history of mankind. Okay, now Wuhan, it was first identified in December 2019 in Wuhan, China, which produced a large cluster of pneumonia cases. Hence, the virus was initially called as the Wuhan virus. Subsequently, it was named as the 2019 novel coronavirus 2019 nCoV. Origin. In further studies, it was found that it's a beta coronavirus with highly identical genome, 96% homology to SARS-like bat coronavirus, pointing towards that bat was a natural host. PHEIC, as the cases continued to rise, the outbreak was declared as a public health emergency of international concern. PHEIC on 30th January 2020. Nomenclature. On 11th February 2020, WHO announced the official name COVID-19 for the new coronavirus disease and also renamed the virus as SARS-CoV-2 because the genome closely resembled to SARS-CoV. Pandemic. The disease spread rapidly in an explosive manner on 11 March 2020, WHO declared it as a global pandemic. By that time, about 114 countries were affected with more than 1,18,000 cases and 4,291 deaths. The explosive spread continued, affecting over 200 countries in the next couple of months. Situation of the world in March 2021 was like the total cases by March 2021 were over 11.5 crore reported with more than 25 lakh deaths, while till 2023 January there were 67 crore and more than 67 lakh deaths have been there. Now, the daily count every day, the 2 to 4 lakh cases were being reported in 2021 with more than 9,000 deaths globally. Highest cases were counted from USA, India, Brazil, and Russia. More than 200 countries were affected, although. Okay, now the mortality rate it varied among the countries and also across the different time spans of the pandemic. With an overall mortality rate about around 1%, it was overall for the whole world. Okay, now in China, rapid rise of cases occurred in China at the beginning. However, the cases rapidly declined thereafter. In Italy was one of those countries which was the worst hit at the early phase of the pandemic. The country was not prepared when the disease started. As a result, there was rapid surge of cases with a mortality rate of more than 10%. USA accounted for the highest number of cases with a mortality rate of 1.8%. And India accounted for the second highest number of cases. However, the pandemic had a slower growth curve to reach its peak in India. India witnessed three distinct waves of explosive surge in cases. The first wave occurred in September 2020, second wave occurred around April 2021, and the third wave occurred around the January 2022. The growth curves of COVID-19 cases vary among the countries. Different countries were at different stages. In countries like Italy, Spain, USA, the disease spread quickly, reaching its peak early, while in like India, the disease had a slower rate of growth initially. Variants that increase in number of cases in various parts of the world in the later phase of pandemic may have been due to the emergence of various variants of SARS-CoV-2 virus such as UK variant, Brazilian variant, South African variant. India was among those countries where the COVID-19 had a slower growth curve and the mortality was around 1.4%. Now coming on to the morphology of the virus, the SARS-CoV-2 comprises of a nucleic acid surrounded by an envelope. It measures 120 nanometer in size, has a helical symmetry, possesses four structural proteins N, S, M, and E, 16 non-structural protein and several other accessory proteins. In this figure, we can see the structure of SARS-CoV-2. From outside to inside, it has a spike protein, the S, membranous protein M, and envelope protein E. Inside, it has a positive sense single-stranded RNA and a nucleocapsid protein, which is labeled as N. The nucleocapsid consists of a positive sense single-stranded RNA, 30 kilobase per genome size, surrounded by nucleocapsid protein N. The envelope is a lipoprotein in nature. The lipid part is host-derived, into which a number of proteins are embedded, such as spike protein S, helps in attachment to the host cells. Neutralizing antibodies are produced against S protein and are protective in nature. It has two subunits. S1 subunit possesses the receptor binding domain RBD, which binds to a specific receptor in the host cell surface, and S2 subunit, which facilitates the cell virus cell membrane fusion. Membrane glycoprotein M, the most abundant structural protein, gives the shape to the virus, and envelope protein E, it's a transmembrane protein and with an ion channel activity found in small quantities. Now, there are some non structural proteins as well. They include several enzymes which help in replication of the virus. Example: RNA dependent RNA polymerase, helicase, etc. Now, coming on to the pathogenesis of the disease, transmission COVID-19 virus is primarily transmitted via respiratory droplets and contact routes. Droplet transmission occurs when a person is in close contact within 1 meter with an infected person. Exposure to potentially infective respiratory droplets occurs, for example, through coughing, sneezing, or very close personal contact, resulting in inoculation of the entry portals such as the mouth, nose, or conjunctiva. Use of mask can prevent droplet transmission. Contact transmission. Transmission of the COVID-19 virus can occur directly by contact with infected people or indirectly by contact with the surfaces in the immediate environment or with objects used on or by the infected person, example stethoscope or thermometer. through fomites, inanimate objects in the immediate environment around the infected person, such as infected clothes, utensils, furniture. Following contact, direct or indirect, the virus can only be transmitted by touching the contaminated hand to a person's mouth, nose, or conjunctiva. Frequent hand hygiene following potential contact exposure is crucial to prevent this type of transmission. Next is the aerosol transmission. Aerosol transmission spread of the infected droplet nuclei beyond 1 meter is not documented yet, although active research is going on in this regard. In specific settings in which aerosol generating procedures are performed like endotracheal intubation, aerosol transmission of COVID-19 virus may be possible. Use of N95 respirator is important to prevent this type of transmission. Now, the pre-symptomatic transmission, it is defined as the transmission of COVID-19 virus from the person who is infected and shedding the virus but has not yet developed symptoms. This type of transmission has been observed in people 1 to 3 days before the onset of their symptom, with the highest viral loads detected around the day of symptom onset, followed by a gradual decline over time. Host cell entry. SARS-CoV-2 enter into the target host cell by the binding of the spike glycoprotein S antigen with the host cell receptor like angiotensin converting enzyme 2-ACE2. This is also the receptor for SARS-CoV. Spike protein cleavage. For the virus entering the host cell, its S protein needs to be cleaved, which is mediated by the host cell proteases, of which TMPRSS2 transmembrane protein serine 2 is important. Fusion. Cleavage of S protein produces S1 subunit which binds to ACE2 and S2 subunit which causes the fusion of viral envelope within the host cell membrane. Then follows the entry of the virus via the endosomal pathway. ACE2 receptors are highly expressed on type 2 alveolar cells in lungs and on the epithelial cells of oral mucosa, also found on cells of heart, kidney, endothelium, and intestine. Therefore, the patients develop extrapulmonary manifestation in addition to the respiratory symptoms. Note, the primary function of ACE2 is that it helps to reduce the blood pressure and has an anti-inflammatory reaction. Now, the development of ILI, like what is called the influenza-like illness, ACE2 receptors are highly expressed on the epithelial cells of oral mucosa. Therefore, at initial stage, SARS-CoV-2 infects the pharyngeal epithelium, induces inflammation. This accounts for influenza-like illness which occurs at the beginning stage of most of the symptomatic cases. Next up is the development of ARDS. The leading cause of mortality in patients with COVID-19 is hypoxemic respiratory failure, which can result in acute respiratory distress syndrome ARDS. It is due to reduced surfactant in lungs. ACE2 receptors are highly expressed on type 2 alveolar cells. These cells normally produce pulmonary surfactants which lower the alveolar surface tension. In COVID-19 patients, the following events takes place. Damage to the type 2 alveolar cells lead to reduced production of pulmonary surfactants, as a result of which alveoli tend to collapse. The air-liquid interface is perturbated, which leads to the fluid retention in the interstitial space. To prevent collapse, the muscular movement of the inspiration becomes hyperactive, which results in increased lung volume and interstitial space. The low pressure area created in the interstitial space attracts liquid, which further contributes to edema in the lungs. Next up is the cytokine storm. The presence of SARS-CoV-2 in lungs induces an uncontrolled generalized immune response. Several immune cells like neutrophils, T lymphocytes, macrophages are recruited to the lung. Acute cytokine influx. These immune cells release pro-inflammatory cytokines like interleukin 2, 2R, 6, 7, 8, 10, GCSF, interferon gamma, IP10, MCP1, MCP3, TNF alpha, and others. Host injury. The elevated cytokines lead to various consequences such as tissue damage and necrosis, further recruitment of leukocytes, impaired gas exchange which leads to reduced blood oxygenation and tissue hypoxia, endothelial damage of pulmonary vasculature leading to vasodilation, microvascular thrombosis and hemorrhage, and hypercoagulability as well. Now, in this figure, we can see the cytokine storm seen in COVID-19 patients. It shows a comparative study between the normal and the disease state. In the normal state, there are bronchial epithelial cells, and below them there are type 1 alveolar epithelial cells. Below them there are type 2 alveolar epithelial cells, and on the outside there is endothelial cell of the blood vessel, junction, and the pericyte. Now, in the disease condition, the SARS-CoV-2 infecting alveoli causes the inflammation of the type 1 and 2 alveolar cells, Pro-inflammatory cytokines causing cytokine storms such as IL-2, 6, 7, 8, 10, GCSF, interferon gamma, tumor necrosis factor alpha, and others are secreted. And all in all, they produce pulmonary edema with neutrophilic and inflammatory cell infiltration. What firstly occurs is the vascular leakage, which causes coagulation and inflammation at the same time. So, all in all, this causes the pulmonary congestion. Next up is the dilatation of blood vessels. Underlying the alveoli, this allows the passage of fluid from the blood vessels into the lungs, which leads to the pulmonary edema. Thus, these infiltrates in the lungs appear as ground glass in chest imaging. Fibrosis in the later stage, there occurs recruitment of the fibroblast, which causes lung fibrosis and ultimately leads to respiratory failure. The stage is called as acute respiratory distress syndrome (ARDS), eventually leading to the respiratory failure. Multi-organ failure cytokines can also induce damage to other organs of the body such as heart, kidney, liver, etc. They occur several catastrophic events such as sepsis, septic shock, and multi-organ failure, including acute kidney injury and cardiac injury. Risk factor. The major risk factors for the disease are age more than 60 years, risk increases with age, and underlying comorbidities such as diabetes, hypertension, cardiac disease, chronic obstructive lung disease, cerebrovascular disease, and chronic kidney disease, immune suppression disease, and cancer. Now, the clinical manifestations of the disease. The incubation period for COVID-19, time between infection and symptom onset, is on an average of 5 to 6 days but can be as long as 14 days. COVID-19 patients may present with following signs and symptoms. Common features: fever, cough with expectoration, fatigue, shortness of breath, myalgia, rhinorrhea, sore throat, diarrhea. Loss of smell or taste sensation may occasionally occur preceding the onset of respiratory symptoms. Atypical symptoms, particularly seen in older people and immune suppressed patients, such as fatigue, reduced alertness, reduced mobility, diarrhea, loss of appetite, delirium, and absence of fever. Children might not develop fever or cough as frequently as adults. Clinical severity. Based on clinical severity, the disease may be classified into 3 clinical stages, like in this table. Mild illness, influenza-like illness with the patient's clinical presentation like patients with uncomplicated upper respiratory tract infection may have mild symptoms such as fever, cough, sore throat, nasal congestion, malaise, headache without evidence of breathlessness or hypoxia. Next up is moderate disease, pneumonia with no signs of severe disease, clinical symptoms like dyspnea, fever and cough, hypoxia, SpO2 less than 94%, respiratory rate more than 24 per minute. And lastly is the severe disease called as severe acute respiratory illness (SARI). Severe pneumonia with clinical signs of pneumonia plus one of the following signs of severe respiratory distress: rate more than 30 per minute or SpO2 less than 90%. Acute respiratory distress syndrome (ARDS). Symptoms like onset of new or worsening respiratory symptoms within a week. Chest imaging shows bilateral opacities not fully explained by effusions, lobar or lung collapse or nodules. Decreased PaO2 upon FiO2. Normal value is 500. ARDs can be classified into mild less than 300, moderate less than 200, and severe less than 100. And PEEP or CPAP is maintained at more than equal to 5 cm of H2O. Sepsis, acute life-threatening multi-organ dysfunction, can occur, clinically diagnosed by SOFA score, sequential organ failure assessment score. Septic shock, persisting hypertension despite volume resuscitation, requiring vasopressors to maintain mean arterial pressure more than 65 mm Hg and serum lactate level more than 80 mg per deciliter account for the septic shock. PEEP means positive end expiratory pressure. CPAP means continuous positive airway pressure. SpO2 means blood oxygen saturation level. PaO2 upon FiO2 means ratio of arterial oxygen partial pressure in millimeter of Hg to fractional inspired oxygen. Okay, so this completes our part 1 of the chapter. In the next part, we'll be discussing about the lab diagnosis, treatment, and the prevention part of COVID-19 infections. Okay, so like, share, subscribe. Thanks for watching.